Hello, my name is Celeste Chow. Today we'll be talking about an article titled, Is Parent-Child Interaction Therapy Effective in Reducing Stuttering? By Sharon K. Millard, Allison Nicholas, and Francis M. Cook. To start off, I wanted to talk about some terms to help you better understand the purpose of this article and what the findings were. The first thing I wanted to discuss was what stuttering is. Stuttering is a fluency disorder that begins during childhood and can last throughout life for some individuals. 70% of children who experience stuttering will resolve the problem, while 30% will experience long-term problems. This disorder is characterized by disruptions in the production of speech sounds, which are also known as disfluencies. Some may repeat part of a word or a syllable of a word. For example, they might say, what, where are you going? Or they might add in fillers in sentences such as or Stuttering can impact daily activities for many individuals. However, the extent of the impact will depend on the individual. Some individuals may only experience disfluencies during specific activities such as answering the phone or talking in a large group, while others may experience disfluencies across a number of activities at home, school, or work. Because of this, some may exclude themselves from activities, speak less, or pretend they forgot what they wanted to say. After seeing the title of this article, I am sure you are wondering what parent-child interaction therapy is. This is the next thing I wanted to speak about before I begin to further discuss the article. So what is parent-child interaction therapy? Parent-child interaction therapy is a flexible approach that can be altered to meet the individual needs of the child and the family. Stuttering is discussed openly, and parents are encouraged to acknowledge the stuttering with the child. The program is designed to empower parents to manage their child's stuttering and increase their confidence in their own skills, as well as seeking to increase fluency in the child. I will now discuss with you the consultation assessment, the format of the therapy sessions, the content of the therapy sessions, and the consolidation period to give you a better idea of what this therapy is. So the consultation assessment has two components, which are child assessment and case history. The child assessment includes an evaluation of the child's speech, language, and fluency skills, and a series of questions that attempt to establish the child's awareness of and insight into the stuttering and degree of the impact that the stuttering has on the child socially or emotionally. The format of the therapy sessions. The structure of each session remains consistent across families. In session 1, feedback from the consultation is reviewed and special time is negotiated. Special time is to provide parents with a designated time in which they practice their chosen interaction target in a relaxed, one-to-one communicative setting. This is considered to be the foundation of the therapy program. The goal is for parents to generalize their skills outside of special time to other contexts as they become more confident and proficient. Session 2 through 6 will begin with a review of the special time feedback form and a review of progress during the week. A parent-child playtime is then video recorded and appraised by each parent. Interaction targets are selected individually, and the rationale for proposed changes is discussed. Parents then practice their target individually with the child during another brief playtime that is also video recorded so they can identify occasions where they have achieved their targets. The content of the therapy sessions. The content of parent-child interaction therapy encompasses two strategies, which are management strategies and interaction strategies. Selecting these strategies is what allows the program to be individualized. Management strategies. Parent-child interaction therapy is explicit about the need to help parents address issues such as managing anxiety about stuttering, coping with sensitive children, confidence building, and other behavioral management techniques such as setting boundaries and routines with sleeping, eating, and turn-taking. Helping parents to recognize and understand how their own emotional state affects their reactions to the child and reducing their anxiety in relation to the child and the stuttering is considered an important part of the therapeutic process. The main principles of management aspects of child behavior are broadly based on behavioral methods. The desired outcome is reduced to a series of achievable steps. The target behaviors required of the child are made explicit, and a reward system is put into place. Interaction strategies. Targets for interaction strategies are selected by parents on the basis of their understanding of their child's needs and their knowledge of times when their child is more fluent. Parent interaction targets may include reducing their rate of speech to match that of the child, modifying their use of questions, increasing response time latency, or reducing linguistic complexity to a level that is appropriate for the child. The consolidation period. When the clinic sessions are done, the parents continue to carry out special time at home and to implement the management strategies they have adopted. The parents mail or email their feedback forms to the speech therapist on a weekly basis with comments about how the targets are progressing and any difficulties they are encountering. The speech pathologist provides written feedback for each sheet. The home-based therapy period lasts for 6 weeks with the aim of consolidating and generalizing the skills developed. Now that you have a better understanding of what parent-child interaction therapy is, let's talk about the purpose of this study. The researchers in this study sought to determine how effective parent-child interaction therapy is with young children who stutter. So they are asking, is parent-child interaction therapy effective in reducing stuttering in young children? What did they think? There is some evidence that stuttering in children can have an impact on an adult style of interaction. Evidence that a parent's interaction style can also affect the child's fluency further demonstrates a bidirectional relationship between stuttering and parent interaction. Through the manipulation of interaction variables, stuttering has been shown to decrease in association with reduced parental rate of speech, increased response latency time, and structured turn-taking. The authors of this study predicted that parent-child interaction therapy would reduce stuttering in preschool children who stutter. So how was it done? So let's take a look at the method. Participants. There were 6 children who participated in this study between the ages of 3 to 4 years old. All children had been stuttering for longer than 12 months. The main language spoken at home was English. They were living with 2 parents, had no therapy in the last 12 months, and no learning difficulties or syndromes identified. Procedure. This study was a longitudinal, multiple, single-subject study with 3 discrete phases. During each phase, multiple child speech samples were obtained. Phase A was a no-treatment baseline phase that lasted for 6 weeks. Parents video recorded themselves playing with their child at home for 20 minutes once a week. At the end of this phase, both parents and child attended a consultation assessment where receptive and expressive language were evaluated. Phase B was a 12-week treatment phase consisting of 6 once-weekly clinic-based sessions and 6 weeks of home-based therapy. Recordings were made weekly. Phase C was a 1-year post-therapy follow-up phase where the child and parents reviewed progress over 3 months, 6 months, and 1 year post-therapy. Throughout the study, families were not informed on any stuttering data collected. During the study, they did a speech analysis where the video recordings were randomly evaluated. Syllables were considered stuttered if they exhibited the following characteristics: monosyllabic whole word repetitions, sound or syllable repetitions, audible or inaudible sound prolongations, or blocking of sounds. The percentage of syllables stuttered was calculated by dividing the number of syllables stuttered by the total number of syllables spoken and multiplying by 100. An estimation of the stuttering severity was made from the first and last recordings based on stuttering frequency, duration of the 3 longest stutters, and the degree of tension and secondary behaviors present. Scores range from 0 being normal speech to 7 being very severe stuttering. And here in this chart, you can see some of the family targets selected, such as to use comments rather than questions, follow the child's lead in play, take shorter or fewer conversational turns, etc. So what did the authors find? 4 out of the 6 children were monitored for the full 12 months post-clinic therapy as intended. The other 2 children submitted videos consistently each month, but completed only 8 and 7 months of the follow-up phase. The results demonstrate that 4 out of the 6 children studied significantly reduced the frequency of their stuttering with both parents by the end of the therapy. 1 child significantly reduced the frequency of stuttering with 1 parent, and the remaining child made significant progress when a direct fluency management program was introduced. The data collected from each child while interacting with each parent were subjected to QSUM analysis, which monitors variability during a baseline and detects shifts of more than 1 standard deviation from the target mean of the baseline. The technique has been shown to be sensitive and effective in measuring deviations in the individual performances over time. Conclusion. The authors of this study concluded that with 6 sessions of clinic-based therapy and 6 weeks of parent-led, home-based therapy, parent-child interaction therapy can reduce stuttering in preschool children. To conclude, I will now talk about the strengths and weaknesses of this article and what future studies should consider. One strength of this study was that it was a single-subject study. This is because single-subject studies allow investigators to identify whether there is evidence that a treatment works before a large-scale study is done. However, single-subject designs also have a weakness in that although the internal validity of this study was high, because the number of participants was small, the participants are not necessarily representative of the population of children who stutter. Therefore, the ability to generalize the results is limited. Another strength of this study is that the findings add to the growing body of data supporting structured intervention with young children who stutter. Specifically, this study provides evidence that indirect methods such as parent-child interaction therapy can be successful in reducing stuttering. Also, this program is evidence-based, which is great. Another weakness of the study is the possibility of natural recovery. Although the likelihood of the results occurring due to natural recovery is reduced by the length of time the children had been stuttering, the possibility cannot be ruled out because natural recovery can occur 5 years post-onset. These findings are important because they add to the growing body of data supporting structured intervention with young children who stutter. As speech pathologists, when working with clients with dysfluencies, we hope to help them reduce the severity of the fluency disorder, and this therapy may be able to do just that. Reducing the severity of the disorder can also help to reduce the severity of the handicap caused by the disorder, increase the client's confidence and motivation for therapy. Future studies should evaluate the program's efficacy with differing populations. The studies will need to focus on the implementation of the program with other clinical groups, such as individuals who require interpreters or those who have concomitant disorders. The number of sessions of parent-child interaction therapy should also be taken into consideration in future studies. Therapy was predefined in 2 6-week blocks. However, it is not known whether this period is the most effective, both in terms of outcome and cost. And that's it. Thank you so much.